Okay, good afternoon, everybody. Thank you. Oh, I didn't remember my talk up. Thank you for coming. We're going to be talking about aortic diseases today. I will be the lead-off hitter, followed by Dr. Quinones. I'll be covering CT and CMR, and Dr. Q will be covering echo, and then kind of a general, a summary of how we can evaluate patients with aortic disease. Now, I think both Dr. Q and I can attest this is a very large subject. We have done our best to try to kind of make it compact for y'all, but there's a lot of different disease entities that involve the aorta. Actually, believe it or not, this is the largest artery in the human body, pumps over 200 million liters of blood through an average patient's lifetime. So, a lot of different diseases that are present in this organ. So I think just to begin, it's very important to know what the normal aorta looks like and how you go about naming different parts of it. So in general, you have the aortic root, which is right after the aortic valve, and it consists of the sinus of Valsalva up to the sinotubular junction. This is then followed by the ascending aorta, which goes from the sinotubular junction to roughly about the origin of the innominate artery. You then have the aortic arch, which consists of from the innominate artery to just past the left subclavian. And then after that is really the descending thoracic aorta until the diaphragm. You have an area there also in the very proximal portion of the descending thoracic aorta known as the isthmus. Once we get below the diaphragm, you are now in the abdominal aorta. Abdominal aorta generally can be divided into three parts. You've got the suprarenal abdominal aorta, you've got the juxtarenal abdominal aorta, and then the infrarenal abdominal aorta. So just gross evaluation of what the different nomenclature of the aorta is. Now, I'm going to be talking a lot about CT and MRI for the assessment of the aorta. And the reasons are because these techniques really, when it comes to evaluating the entire aorta, are really the mainstay of evaluation. And there's many different reasons, and I hope to highlight with the talk. But some of the things that you've already heard about, they've got very wide coverage, they've got excellent image quality. You can see all the branches, you can see all the side branches. You can manipulate these 2D and 3D data sets with post-processing, which is very helpful. And then finally, because it's got large field of views, you can actually evaluate structures that are perfused by the aorta. And so they therefore diagnose disease processes in other organs as well. Now, when it comes to CT and CMR, both of them are excellent anatomical tests. A lot of my talk will be spent showing probably 3/4 CT images, 1/4 CMR images, not because CMR is at all inferior in imaging. It's just that's what I could quickly acquire. But, and to be honest with you, the images by CMR look exactly the same as CT. So a lot of my images will be, so consider them equal. So how should you choose who should get which test? We'll be going a lot into that. But just some key things about the patient you should remember. CT is generally readily available in your ERs. It's got very short scan times. It's better for patients who are unable to lie flat for too long. Or claustrophobic patients. It doesn't have any problems with metal. May be helpful if you need to know the coronary evaluation as well. CMR has a lot of other facets to it that can be advantageous to you. Of course, it's very helpful for tissue characterization. It can also provide functional analysis of the heart should you need. It definitely can tell you a lot more about aortic valve pathology and function. Consider in patients who are allergic to iodine or those who have significant renal dysfunction. Remember, we have ferromoxetol. A new and upcoming trends for evaluation of the aorta are, of course, 4D flow, only provided by CMR. And then, of course, it's radiation-free and can be very helpful in the young and for serial imaging. Now, when it comes to recommendations how you should do vascular imaging, it's very important that we want to, whenever we report measurements in our reports, we want to do them at reproducible anatomical landmarks. Those are the same landmarks I mentioned when I described to you the normal aorta. Next, it's also very clear how, with these two techniques, you should make measurements. They should be the external diameter, so the outer wall to the outer wall, and you have to be perpendicular to the axis of flow. So, we'll come back to all of this. So where are your standard anatomical landmarks for describing the aorta? This is all well described in the literature. Pretty much, if you've sat with us in CT or CMR, we are reporting these exact same measurements on all our report. And it becomes very important because, when this patient comes back for evaluation, whether this aneurysm or enlargement is getting bigger, it's so important to be able to compare it to the old report, to the old study on direct analysis, and then to be able to make measurements in exactly the same places. When we do imaging, especially with CT, it's so important to gate the images. If you're not gating your images and you have an inferior temporal resolution, you can get these pulsation artifacts which can mimic dissections, can make measurements very, very difficult because you don't know where the outer wall is. So always gate your images to get rid of this pulsation artifact. Now, how do we measure this external diameter? So the recommended technique for both CT and CMR is what we call the double oblique method, where in two different views using two different views, you create a true short axis of the vessel in question. And then once you have the true short axis, then you're able to measure from the outer, the external diameter, which is the outer wall to the outer wall. Now, and it's important, I'll mention in this case that it's important, remember when we make these measurements, it's not a luminal diameter. So a lot of these aortic diseases have pathologies where the wall may be thickened, where there may be overlying thrombus. So you actually are not measuring just the lumen itself, you're actually measuring the whole wall plus the lumen. So that's kind of an important point. CT has made it kind of easy now. All these advanced software algorithms have a center line which kind of just tracks the entire aorta through a center line. So you literally can move point by point to any location you want to make a measurement in, and the computer will give you what the true perpendicular cross section to that point is. And this is just an example of what happens if you don't really make a true a perpendicular, using the double oblique method. If you don't do that, it becomes really consequential for very tortuous vessels. Here's a great example. If you just make a simple axial measurements, which sometimes we often do, in a vessel that's very tortuous, you can grossly overestimate the degree of enlargement. Whereas if you truly do make a short axis measurement, as the picture in the bottom right, the dimension is very different. Sure, both are very enlarged in this particular setting, but you can see the difference in magnitude. Now, when it comes to what is normal, there's also a lot of literature out there, and that has been published using mostly CT as to what normal aortic sizes are. And this is a graph just showing you that. And, I won't spend too much time on it. I want to just kind of give you some flavors about, there's data out there that shows you that, number one, your biggest measurements are really at the ascending aorta. So, a couple of things to take home. Number one, that the aorta tapers. So you're from the ascending aorta all the way down, the aorta gradually tapers. So if you have a descending aorta that's about the same size as your ascending aorta, and even if those values are normal, that's abnormal for that patient, because the normal aorta should taper. And I think that's what this graph is trying to portray to us, that from the ascending aorta, it should be tapering down. Second thing is, measurements are not so easy when you're trying to describe what is normal. And this is, Dr. Q is going to hit on this, so I'm not going to spend too much time, but this is just a graph showing you that the ascending and descending aorta in the red and blue lines, that they're, in this particular graph, vary by age. So as we age, the aorta, I guess, enlarges and folds, whatever you want to call it. And it's not simply age. It's been shown that aortic diameters are influenced also by sex, BMI, BSA, and then of course the location and the methodology of how you're measuring. So those are important things to take into account when we're trying to decide what's normal and abnormal. And this is a graph Dr. Q is going to hit on, aortic root diameters at the sinus of Valsalva, proximal ascending aortic diameters, and what was considered to be a normal cohorts in patients less than 40. You know, if these diameters, look at as the body surface area, as the bigger the person, you know, you would expect the aorta should be bigger, and this is what this shows. So there is some variability when we're describing these aortic measurements, depending on other factors. I bring this up because it's kind of important when talking about these pathologies. What's normal? What's an aneurysm? What's a false aneurysm? What's a dissection? So true aneurysm is when all three layers, you know, dilate out. And generally, we define an aneurysm when there is a 50% increase in the diameter. So a lot of times we use this word, you know, aneurysm, but, you know, and the measurement may be, you know, 4.1. I don't think that's correct, you know, at least for the thoracic aorta. You know, the true definition is 50% greater than normal. Pseudoaneurysm is when you have, you don't have all three layers. Usually you have a rupture of the artery, and, you know, that one layer that looks like that's containing the vessel is really just adventitious tissue.
I guess one question I would ask, I mean, so if you say the normal thoracic ascending aorta is 4, and that's saying if you say the normal ascending thoracic aorta dimension is 4 centimeters, if you require a 50% increase before you call it an aneurysm, then you're not going to call it anybody an aneurysm until 6.
Yeah, 5.56. And I'll tell you why I don't think that's unreasonable, because we'll come back to that. But all the surgical treatment starts when it's that big. So maybe it's not unreasonable, you know. It is definitely enlarged, but the definition of aneurysm is 50% greater than the mean. And that's the difficult part, is defining what the normal mean is for this patient, you know.
Yeah, I mean, I guess maybe it brings to the question of, do we need to revisit this definition of aneurysm?
It's also, I think there's also a geometric component, because you may have hypertensive patients, for example, frequently have a diffuse dilated ascending aorta. It's all 4.1, 4.2. There's no geometric change. It's really a parallel increasing aorta. Where once you get into aneurysmal dilations, even dating back to the dates when Dr. DeBakey defined many of them, you usually had, at some segments of the aorta, a geometric distortion where you had the actual dilation coming down, coming up. So I think if you include geometry, which you can assess so beautifully with CT or CMR, I think we get less of a confusion versus just what we would call diffuse ectasia, which is a diffuse enlargement of the vessel. Mm. So I think paying attention to the geometry, I think, makes a lot of sense too, besides just numbers.
Yeah. Okay, so I won't spend too much time, because I have to definitely give Dr. Q plenty of time as well. There are a lot of different pathologies we should be aware of. You know, starting from the sinus of Valsalva, you know, I mean, starting from the aortic root, and this is just an example of sinus of Valsalva and aneurysm. You have to be very cognizant of different aortic arch variants. We have a vascular surgeon, you know, that's very important for them when they're deploying their devices, what type of arch it is, where all these branch vessels come off. Some normal findings of an aorta, the way it looks, so these are all very important to know. And even how different vessels take off from the arch. Believe there are many different types of variants, and within the range of normal. This is just an example of a coarctation, you know, and which is considered a very narrowing, a tight narrowing just past the left subclavian, and, you know, just to give you some images of some pathologies considering for the aorta. Here you often hear the term porcelain aorta. What is a porcelain aorta? This is it, you know, where you have diffuse calcifications. It generally indicates long-standing atherosclerosis and inflammation, and it's a major problem for our surgeons, with the risk of any type of manipulation leading to either dissection or strokes. So, you know, this year I kind of added this slide because, you know, both Dr. Q and I are going to jump right into the acute aortic syndromes. But it's so important to keep in the back of your mind, especially those of us who are looking at this organ every day, that there's a host of diseases which are low on the radar of a cardiologist sometimes. And we have to keep it aware in order to be able to make these diagnoses. And these are inflammatory diseases. So this is, on the picture on the right are a sequence of images of Takayasu's. And Takayasu is not the only arteritis. There are others such as giant cell, Behçet's, ankylosing spondylitis. It's so important us to be aware of them and how they present. And at least for Takayasu's, generally the onset is less than 40. Here you see a lot of tapering of the vessels. There's a lot of involvement of the vessels coming from the head and neck. So it's just things that, if you're not looking for it, you're not going to make the diagnosis. But this is more common probably than we think. So jumping into aneurysms before we get into the syndromes, this is actually, it's a silent disease. It's becoming more and more common with all the imaging that we're doing. And thoracic aortic aneurysms have a very strong genetic component. That's one thing I'd like to point out from this talk. And these are all the different diseases that genetic diseases that affect the thoracic aorta. These are all the diseases you've heard of: Marfan's, Loeys-Dietz, Ehlers-Danlos, Turner's. They're important not only because they have a genetic origin, but also the decision to when to operate is much different from the average atherosclerotic population that we deal with. And this is just an example of an ascending thoracic aorta from a Marfan's patient, where you have effacement of the sinotubular junction and this marked, bulbous-looking ascending aorta. Believe it or not, there's families who have thoracic, who may not have the specific genotype, but in their families they have a history of thoracic aortic aneurysms, and they've identified some mutations. So bottom line is when you're seeing patients with dissection, ask them about some of these, whether they have a history, a familial history of any thoracic aortic problems. Bicuspid aortic valve aortopathy, very important to know, affects 1 to 2% of the population. 20% of bicuspids will have, of course, concomitant ascending aortic aneurysms that will require repair. And 15% of patients with dissection have bicuspid aortic valves. So major, major problem. It's a class 1 indication, that the first degree relatives should be screened. It's very, very important. And that patients who do have bicuspid valve should have some imaging, be it beginning with an echo to start identifying pathology. What's interesting about aneurysms is that the disease above in the ascending is often very different from the disease from the descending. The disease above in the ascending and arch is often is non-arteriosclerotic. It's often the familial genetic type, often due to medial degeneration. Whereas disease that's in the descending thoracic aorta, and of course extending into the abdominal aorta, is related to atherosclerosis. So two very different pathologies, kind of very interesting. When we look at when things start going bad, this is just a graph showing you, I've highlighted where I kind of want your eyes to go. In the thoracic aorta, once you start hitting 6, every sort of complication you are interested in, the graph starts taking off. And this has been shown in multiple studies. Here's another one. You get this little blip after 5. By 5.5, you definitely have increased risk. And by 6, whether it's the ascending or descending, you have major risk. And this is another one, just showing you, again, multiple studies showing you that as your thoracic aorta enlarges beyond 5.5, 6, you're getting into trouble with survival. So, there are graphs out there that can help us trying to index to BSAs, trying to figure out what's normal. And here, if definitely once you hit 4 centimeters per BSA, you're kind of in a danger zone. So I would remember 4 as, a severe risk of abnormalities. Now, when it comes to when do you treat these patients, this is actually kind of new stuff that I came across. First of all, for when you're dealing with the ascending aorta, treatment is at 5.5. And so, of course, or if they're symptomatic or growth rate is very fast. Bicuspid valves, if you remember, we've had this disagreement between the thoracic aortic guidelines and the valvular guidelines. Well, in 2016, they published 1 or 2 page consensus document where they got together and hammered this out. And now official statement from the ACC is that for bicuspid valves, the size is 5.5 centimeters. So they are treating bicuspid valves no different from ascending aortic pathology.
I think what they did is they said it's a class 1 indication at 5.5.
Yes.
It's a 2A and said it's reasonable at 5.
Right.
Kind of really punted and didn't really.
Yeah. Well, you don't have the discrepancy between the two groups now. So they kind of hammered it out,
But in the sense saying it's between 5 and 5.5. Because it's reasonable at 5. And
Class 1 at 5.5. And then,
Class 2A.
yeah, if they have symptoms, history of dissection, other things like that, then you could consider operating early. So what about those who have genetic or familial etiologies? Cutoff criteria is much lower. It's around 4.5 to 5. So that's the important thing to remember about Marfan's and Ehlers-Danlos and Loidites, etc. What about the abdominal aorta? So it's very easy now. The ascending aorta is 5.5. Abdominal aorta is 5.5. So just remember, the entire aorta, 5.5. As soon as you start hitting those numbers, it would be class 1 indications. As long as they're not symptomatic, it's class 1 indications, 5.5 centimeters entire aorta. Okay, not to mention, we should talk a little bit about it. When you have an aneurysm, please consider medical therapy. It's been studied. Risk factor modification, stop smoking, put them all on beta blockers, especially Marfan patients, ACE inhibitors, all been shown to prolong life and slow the growth of the aneurysm. Okay, so acute aortic syndromes. Now, these are a conglomerate of diseases that often share very same presentations and similar pathophysiology. And so, they're frequent. They're about 3 to 6 per 100,000. I mean, enough that we see them every day in this hospital. They increase with age. Vast majority are aortic dissection, followed by intramural hematomas, followed by penetrating aortic ulcers. If you look at the classic age, you've got your middle-aged male, 60 to 70, middle-aged, I don't want to offend anybody. They generally have a history of hypertension, and their classic symptoms are chest pain or back pain that they consider sharp or tearing. So anybody who has hypertension, who comes in with chest pain, I think you got to keep aortic dissection in the back of your mind or you're going to miss this disease. And interestingly, the symptoms of dissection in these syndromes is very varied. They can come in heart failure, they can come syncope, they can come in with acute strokes, abdominal pain, ischemic legs, paraplegia. I mean, this is a disease that we have to consider for practically every cardiovascular patient that is admitted in our EDs. So this is just a nice graph that's been published, how to help you think about it. Think about the high-risk conditions, familial history, Marfan's or bicuspid valves. Do they have high-risk features, which is really just chest pain or back pain that's sharp or tearing? And then do they have high-risk physical features, meaning pulse deficits, new murmurs, and don't forget about hypertension. Now, pathogenesis, we're going to be talking more about this, and I'm going to skip some slides so we can stay on time. It's important to know the classification of the aorta. There's the Stanford A, which involves the ascending, DeBakey type 1. DeBakey 1 is both involvement of the ascending and descending. DeBakey 2 is just limited to the ascending. Stanford B is just the descending, which is your DeBakey 3. This was a large meta-analysis just published. It'll come up in future slides, showing us, the diagnostics, what is the diagnostic accuracy of the tests, and for my part of the talk, I highlighted to you CT and CMAR, which are really foolproof in making this diagnosis. This is the classic study that's often presented, the New England Journal, which a single study which also showed very high diagnostic accuracy. This was a large meta-analysis with multiple studies. Imaging, very important in these diseases. You get a whole host of important information that's important for us to talk about, from the flap, what vessels are involved, what organs are being compromised. Is there rupture? Is there perforation? Is there evidence of impending rupture? Things that we have to look for in order to notify our physicians. Medical therapy of AAS, very important. Control the blood pressure, control the blood pressure, control the blood pressure. But the first drug you reach for is a beta blocker. You have to decrease shear stress, then follow that with blood pressure control. Because if you give a pure vasodilator, you'll actually increase shear stress and worsen their prognosis. So control the blood pressure, beta blockers first, then get the blood pressure below 120/80. And then, of course, risk factor modification. Treatment is simple. So if it's Stanford A, they're going to surgery. That's the class 1 indications. They have some trials under place for stent grafts, but for boards, it's simple. Type 1 goes to surgery. Stanford B, you now have a choice. If it's uncomplicated, it's medical or TVAR. And if it's complicated, it's TVAR. And that's becoming more and more apparent to us as we go along. And then, of course, with the Bs, you want to watch them very closely because they can progress, and with serial imaging. This is just graphs showing you now the treatment recommendations for acute aortic syndromes. And this is, these patients have to be followed for a lifetime. This is just showing you that with these diseases, how often you have to perform imaging. So aortic dissection is a tear in the intima, and you have blood flow that gets into the media and creates this double lumen. It has a very high mortality for ascending, where it's 1 to 2% per year and per hour, and therefore why you need surgery. Most common cause, again, is hypertension. Here's some different things that have been associated with aortic dissection. I'll point out to you hypertension. Think about it in your cocaine user who comes into the ED. It's not always coronary. Weightlifters, trauma, of course, and of course everybody who has genetic issues. Believe it or not, they occur in people who have small aortas. So this is a table showing you patients with aortas less than 4.5 centimeters can come in with dissection. And of course, there's probably other etiologies such as some genetic component or medial degeneration or whatever it is, but don't be fooled by normal aortas. Don't just be thinking dissection in big aortas. Non-contrast CT can help you with dissections. Believe it or not, the intima, the calcium gets displaced into the middle of the artery, and we can see that very nicely with a non-contrast scan. And here's the same corresponding CT scan showing you that image, showing you the pathology. Contrast CT, of course, is the workhorse. Many different things. You're looking for a double lumen. You're looking for this intima that's torn away from the media. You're measuring sizes. You're looking for their features that help you figure out whether things are true lumens or false lumens. You're looking for complications. And here, if you look at the sequence of images, you've got dissection of all the arch vessels, the mesenteric vessels, and in this particular case, the renal vessels. Here are some real big complications you worry about: pericardial effusions, as well as coronary artery dissections and pleural effusions. This is really pretty much blood in these spaces. There's a whole host of complications you should look for, especially when we evaluate these images. I put this table up because, I guess, all of us, when we read these images, have to be aware this is a disease that affects multiple organs, and these CT data sets or MRI data sets have tremendous amounts of information and can really change the prognosis of a patient. CMR in aortic dissection is also excellent, as we mentioned, or how disappointing. One thing I'd like to mention with CMR is often gets blamed for being a slow technique, but literally you can do these bright bloods through the chest. They're non-breath hold. The patient is free breathing. You put them in, takes just a few seconds. You can get a full set of images through the patient's chest and abdomen. And this was working in my office. I'm so sad it's not playing here, but it was really an amazing case, which, Akshay, you'll be reading today. It was a very nice type B dissection, and you had a retroesophageal right subclavian, and you can see the dissection going into that as well. So I'll figure out why this didn't work. I'm really disappointed. And it's on the same story over here. Other things we can learn with CMR, which we can't with CT, is dissection mobility. It tells you how chronic that dissection is. It can tell you how well their grafts will hold and this and that. Also with time-resolved MRA, you can also tell flow through the aorta and also look at flow patterns in the true and false lumen and how the aorta will remodel. So very helpful. CMR, because it's a dynamic test, can also show you dynamic obstruction. In this particular case, that during the true lumen would, which these mesenteric vessels were coming off would actually be occluded because the false lumen was pressurized, and that flap would go and occlude one of those vessels. So it can be very, very helpful. Intramural hematoma is when you just have rupture of the vasa vasorum and bleeding into the media. This is, again, the things to remember about this: 1/3 can resolve, and 2/3 can go on to aneurysm, rupture, or progression to dissection. Again, non-contrast CT is very helpful. In fact, our protocol for all aortic cases is a non-contrast first. Blood has a very high Hounsfield unit, fresh blood, so you can see this concentric intramural hematoma just on a non-contrast scan. And then when you give the contrast, you have to be aware of this. You see this, you won't ever find an intimal tear, but you'll see this spiraling concentric darkness around the lumen of the aorta, and that's your intramural hematoma. And this is what it would look like. CMR can really show it to you because you have so many different sequences that can display things in different tissue contrasts. They are high-risk features, which I learned about, which you have to be aware and should report in your reporting, because this tells the vascular surgeon that, hey, this may not be the third that go ahead to resolve. And those are if the aorta is very large or the thickness of that IMH is more than 11 millimeters. Penetrating aortic ulcers, atheromatous ulcers, are basically always in areas of dense atherosclerotic plaque where you just have bleeding into the media and this, this invagination into the wall of the artery. Here are some classic examples of that using CT. This is just where you've got blood now into the media of this vessel. They're focal, wide-mouthed, outpouchings, generally in areas of heavy atherosclerosis. Okay, and this was a PAU, in the arch, and I like to show it because remember, 2/3 go on to progress. This one went on to progress to a saccular aneurysm. So other things that are important for us as docs is, we don't see this, but believe it or not, we've come across 1 or 2 patients who were asymptomatic, who got scanned and had traumatic aortic transections. So you have to kind of know what to, that if you see this, how to make the diagnosis. And for us, both in CT, CMR, this is now becoming a big part of our business, is knowing about endoleaks and making the diagnosis. And, these are talks for another day. Okay, thank you.
So as I get ready here, this is really a topic that, in all honesty, might be best to have in 2 sessions, because if you try to download the PDF of that ACC-AHA document, it takes as long as downloading a big image file. It's a huge document, as FAISAL said. So there's a lot of important information, and it's really, we don't do justice with a session that are fragmented like we had to do today. So maybe for future time, we should consider breaking it into more than 1 session. Let's see. Okay. So I'll try to go, my purpose today is really just to bring in the role of echo, because it is still important that we all stay tuned with it. Why is it that I cannot? Okay. So I like to cover imaging views, some measurement issues, the acute syndromes, and something important where TE really gives a very good look at is this pathology of aortic debris. Now, for some reason, here we go. You saw this. This is the document that takes forever to download. There's another one from Jace that it's a multi-modality image. There's a fair amount of agreement between them, but this one obviously spent a little bit more time just on the imaging side. The other document covers everything, pathology, descriptions of diseases, therapy, and so on. So talking about, I'm having the same problem that you were having. That the images are not playing. This is crazy. What's going on? We're having exactly the same issues. You had the same problem.
Yeah,
I'm having the same problem.
I had put it onto I was running it from the desktop too, and you're running it from your own.
Yeah, and this thing never has a problem. What does it say? You need to upgrade something? This is crazy. What's going on?
Where are the videos?
He has played perfectly. 100 times he has played perfectly. This is absolutely unheard of. Okay, let's try now. All right, hope that it works. So from transthoracic echo, of course, the ascending aorta is the one that we see the best. And it's important for the sonographer that they really take a little extra time in moving the plane a little higher up so that you can see. Why is it that I cannot see the mouse in the screen? Oh, there's a little thing here that you have to say, display settings, right? Is that what it is? Duplicate site? Will that do it? Can you all see? Yeah, there we go. Okay. All right, so it's important for sonographers that you spend time to try to see, because you can, with transthoracic echo, you really can do a fairly good job at keeping a track of the size of the root and the size of that proximal ascending aorta. And that can be very helpful on a patient by patient. Now, the arch, of course, we see through the suprastellar notch. And the descending aorta, you see it on a short axis view in between, long axis and short axis. If you put the transducer parallel to the spine, you may be able to see the descending aorta. This happens to be a patient with a dissection. With TE, we see the aortic root very well at about 120 degrees. At about 100 degrees, you can see very well a big portion of the ascending aorta. And then, of course, descending is very well visualized all the way to the arch. And then we have an area here. This is the arch. This area between here and there could be a blind spot, which is one of the areas where TEE could miss pathology just because the trachea gets in and you have air. So that is the weak link in TEE to make the diagnoses of localized dissections or intramural hematomas. Other than that, you have a good look at the aorta, even down to the proximal descending aorta. So there was this document that talked about recommendations for measurements, and I put this quote from it, the document. Unfortunately, there is no uniform method of measuring the aortic root. I agree 100% with what FAISAL said, that probably outer edge to outer edge gives us the most defined measurement that would agree with the pathology seen by the surgeon. However, echo was done with leading edge to leading edge, and the importance of that is that the measurements that we use for normality are based on that. And other techniques vary. So in this particular statement, they actually tried to get together for a convention, and they still had the struggle. So even though from an echo point of view, leading edge to leading edge is recommended, I think when we are in our day-to-day practice with aneurysms, I personally like to go all the way out, because that's the one I think we have more agreement. Recognizing, though, that normal measurements will be slightly different, because the measurements that we see in all these documents for normality were done with leading edge to leading edge. And we just have to accept that that's reality today and do the best to deal with. It's a 1 millimeter difference, but it still could be at times important. And just to stress again, as we get bigger, the aorta gets bigger. You saw that slide already. In younger people, the influence of body surface area all the way to a 4.2 centimeters in a very big person. And you saw this slide. This slide basically, what I like this one, actually, if I were going to have one slide in the echo lab, that would be the one I have, because this one incorporates body size and aging. So as we get older, the aorta gets bigger, but what this tells us is the upper limit. So this is the upper limit for the ascending, upper limit, and this one is the upper limit for the descending. Now for us, the ascending is the most important because it's the one that we can track by echo a little bit better. And this is another example. This patient had already established a 48 millimeters by CT or CMR. So we can see that we can actually get exactly the same measurement. So in this patient, if we're following it on a yearly basis and all the patient has is an ascending aortic aneurysm, no pathology in descending, we could probably do the CT every 3 years and the echo every year. And that saves money and saves some radiation. So, I mean, or CMR. I mean, we could do either one of them. So you can pick the patient, and in some situations, I think, and I do it in my own practice, I use the serial yearly echo, and then I use the CT or the CMR, depending on which of the two I had started with, as a more periodic, a little bit more stretched, particularly in patients that appear to be very stable, that are not changing very rapidly. However, no question about it. To evaluate the whole aorta, you need one or of those two techniques. This patient is hard depressed. This was last week. So you can see the ascending aorta gets bigger here, and look at the descending aorta. We can actually see a lot of geometric distortion and aneurysmal formation of the aorta. This is thoracic aorta becoming abdominal. So this is the tail end of that big aneurysm. And in fact, we got these measurements done by 2D, so that we had 3.1 for the root, 4.3 for the ascending, 4.9 for descending, and it was between 4.8 and 5 by CT in the descending. So, I think that we can frequently obtain measurements that do agree with CT or CMR on a patient by patient. If you're able to get good imaging, good agreement, then that could change how you do some of the serial assessment. Personally, my own bias is that I would do that more for ascending aorta and less for descending, because I think descending obviously has a lot more complications and tortuosity and issues that I would trust better doing a serial CT or CMR. And you already talked about this, so I'm going to pass about the recommendations for surgery. And you know already about these three entities. What I like to do is spend a little time on how echo can guide you with them, just because when you finish your practice and you go to practice in other places, you may not be as blessed as we're here with outstanding CT and CMR. Remember that the CT that FAISAL showed you is gated CT. Very important. You didn't use that term, but I think I like to stress it. It's what we do here. Now, more and more institutions are beginning to use gated CT, but still many places out there, they have the good old radiology sitting in the box doing a regular CT. And there are big differences between what you get in quality, resolution, between that type of CT and the gated CT, and forget about CMR. Many places still don't have the quality that we have here. So you may have to pick up your probe and use it in these entities. I'm not going to talk much about this since we don't use them too much. And you know this already. And you know all of this already. Basically, this is again from the document of the guidelines, urging a definitive imaging of the aorta using any one of these imaging techniques is recommended to identify the acute pathology. Now, in that document, they talk about, and I'm going to show you the full chart that goes with this, but they basically suggest that if the patient is unstable, that TE is preferred. I would say that's probably true. However, FAISAL make a very good point. If you're in a facility that you can rush that patient to a CT and get a very good gated CT quickly, it's almost kind of a tie between those two. I mean, you still have to get somebody that may be at home to come in to do ETE. So I mean, this whole issue of timing may be arguable, but no question about it that TE is bedside. You can do it anywhere, in the ICU, any place, and many years back, we did a lot of them before we had the quality of CT and CMR that we have today. They always talk about CMR being perhaps more for the stable patient that has a little bit more time. But again, you heard FAISAL talk about the fact that you can actually do a down and dirty very quick MR too. So these things vary, and they're going to vary a lot in terms of where you end up doing your practice. So this is that chart that is very, very long, very complicated. So I'm going to try to break it into little pieces. And this upper part you saw already. Dr. NABI showed you this already, which is when the patient presents, is to try to first highlight whether the patient is, hey, this is cool, huh? I can do this, huh? Can you do that in your laptop? That's what happens if you have a touch screen. Okay, so you can put the patient into what you call is a high risk. These are the high-risk features that come in from the history, like he said, Marfan's, history of Marfan's, family history of dissections, from the physical examination, or from other laboratory findings that you get. So you have this red light that is telling you, whoops, this patient could be a patient with dissection. So there from that, you go to this scheme. In this scheme, basically what it is that if the patient falls into the low risk, basically you're going to follow the typical chest pain algorithm that we use, unless there are some other issues. And the most common issue that they talk about is hypotension, or the chest X-ray smells like a possible dissection. So, because this is your low-risk group. The low-risk group, they have other features, you're not too concerned, but then either a chest X-ray comes in, giving you a red light, or the patient starts becoming hypotensive. Those are obviously red lights. But otherwise, they tend to be on that low-risk category. The intermediate risk, obviously, could have also, if they have an ischemic EKG, they're going to go by way of usually the ACS pattern. Again, if your chest X-ray suggests, or your history has some suggestive findings that makes you concerned with dissection, you're going to want to do what they call expedited aortic imaging, which again is what I showed you earlier. Either you go for a CT, you go for a CMR, or you go for a TE. And that was the part I showed you a little earlier. And that's, again, repeating the same thing. Again, with the caveat, they suggest that if the patient is unstable, TE might be the best route. But I think this depends a lot in where we practice, what kind of expertise we have. And of course, if the dissection is ruled in, you're going to treat it, and FAISAL did a great job showing you the different ways. And if you rule out, then you move to exploring other diagnoses. Because of this concern, and because of, unfortunately, in the US, we, in the emergency room, a lot of doctors practice with the fear of lawyers. Some groups have suggested the so-called triple rule out, which is to have patients coming with chest pain, and instead of having a doctor that thinks and makes a judgment, they throw them all to the CT to look for either CAD, pulmonary embolization, or a dissection. I personally think that is probably, that itself should be going for malpractice rather than the other way around. But I think when you have the judgment of a good physician, you should be able to make then the decision when you use these techniques appropriately. And the last session that FAISAL and I did was in acute chest pain, so we went through a lot of those algorithms. So I'd like to spend a little time with you guys on the actual TEE, because that may be what you have. And when it's like this, it's very easy. It takes 3 minutes. You put the probe in and you go, oh my God, okay? So that's a type 1, type 2, nobody argues with that. Everybody sees it. This is a type 3 or B. Starts right after the subclavian, and then it keeps going down. I'm going to show you more of this patient later. False negatives are very, very few, but there's some. And usually it's because of either having a blind spot, that area that I showed you earlier, or a very small intramural hematoma that you may miss. Most dissections, you're not going to miss. You're not going to miss. But you can miss a small intramural hematoma. Penetrating ulcers, you ain't missing that one. So again, reviewing that area right here at the distal arch is where you may have a small intramural hematoma or localized dissection, and you could miss that. False positives are a little bit more of an issue. And those are 99.99% artifacts of reverberation. Sometimes if you have a thrombus, you could, but to be honest, with a little bit of experience, this is not an issue. The biggest issue is the artifact. So, do we have a dissection or not? You see that little thing flinging there, okay? Well, that is a very nice reverberation artifact coming from here, okay? This is not a dissection, and I'll show you the trick of how to know that it is an artifact, okay? So intimal flaps are free oscillating. They have a free oscillating movement independent of the cardiac cycle. Remember, the aorta is a vessel, and it's going to move a little bit like this with systole and diastole, where the flap inside is just doing its own thing. It's dancing at its own rhythm. It's not following the aorta. And that is the way you figure it out, because look at this one here. That one really makes you look twice. That one is not like the first one, the one I showed you earlier. I mean, you look at this one, you go, uh-oh, could that be? Here's your end mode. And you can see now that this is absolutely going in parallel with the walls of the aorta. That is an artifact. However, it makes you look twice when you see it on the image. Of course, the other thing is that you don't see it spreading. If you put color flow, you won't see any false lumens. I mean, there's many other things you can do. But one quick maneuver is just to throw an end mode there and show that it's moving parallel, whereas the flap has a whole different ballgame. Look at this one. This is very subtle in this view, very subtle. But if you can see it, it has a movement of its own. And when you see it on this view, it's more convincing. Look at that. See, that's have a movement of its own. And now we even start catching right there. So actually, this was a type 2. Okay? So it's not how bright, how brilliant it looks. It's other features. Mobility, particularly mobility, 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 mobility. You know. I'm going to move to that one. A couple of things, though. You can put a T-probe in the neck and take a quick look at the carotids, which we did in this case, and saw that the flap was moving. I mean, it takes you nothing. Once you're done, you pull it out, you clean it a little bit, put some thing, and stick it in here, and do that. Takes you nothing. Literally, this took less than 1 minute, okay? And now you know there's also a flap going into the carotids. This is an important point that we need to bring. Is that looks like a lot of AI. Should the aortic valve be replaced? And how well do you see that by getting CT? Do you guys see it well too? The whole flap going into the LV and showing that it's just a prolapse of the...
If we acquired images throughout the cardiac cycle, we can play a CT.
Okay.
If it's just a snapshot at a...
Yeah. So again, there are a few little things that echo has an advantage, and this is one of them. Of course, it's time frame. So you have this, you can see beautifully the flap going into the LV, and that is, it's AI, but it's AI because the flap is interfering with the aortic valve, and all you need to do is repair the dissection. You won't touch the aortic valve. Versus having truly a situation where the aortic root had expanded, which we see too, the valve has been pulled out, and now you have that with a lot of AI. That's a whole different situation that's going to require a lot more complex type of surgery to manage. So this is the same case I showed you earlier when I showed you a type 2 that started at the arch, and I said, you know, it starts right after, below the subclavian. This is the rest of the story with this patient. So you can see very nicely the true lumen here, the false lumen there. Not uncommon, the false lumen is bigger than the true lumen. But then look what happened somewhere else. Oops. Oh, these are information that, the information that you need. This should be the one. Let's see. Okay. Okay. So here is the dissection. This is false lumen, and now you have this. Okay? I'm going to show it one more time. because it's very cool. And also very important that you recognize. So this is the flap there, false lumen, then there's a break, and you have this here. So this is the fear of dissections, right? Rupture and death. This patient, it ruptured, but a lot of tissue around it created a patch and contained the rupture. So these are called contained ruptures. They are no different from a free wall rupture in an acute MI, where you're lucky enough that a little bit of the pericardium and gets in there and puts a little patch and keeps the patient alive for a little bit. So this is what a contained rupture looks like. And this patient actually made it to the OR to be fixed, but obviously he had a few angels up there. But that's exactly how it looked. So you see the true lumen, the flap, you see the false lumen, and then you see a break, and you see another chamber. And of course, there's always thrombus, because that's what's keeping it from rupture, from free wall rupture. Another example of the intramural hematoma, but this is how it looks by echo. Same story. So FAISAL show you beautiful, this crescent thickening of the wall, and this is exactly what you see when you do your TE. So it's the same concept. It's like having LVH. It's like having a piece of muscle there. It's like that crescent thickening around the wall of the aorta. Very similar to what we see. And this is what a penetrating ulcer looks like. Again, as FAISAL mentioned, there's calcium everywhere. You see all this brightness of calcium. Look at that, everywhere. Diffuse calcification, and then a neck and a big area here, and all of this is clot. And this was a 62-year-old guy that came in with severe epigastric pain going to the back. They thought initially that he had a perforated ulcer. And they did the CT for that, and then bingo, the aorta didn't look so good. And we did the TE, and he went straight to the OR. So this is taken from one of the articles on that, again, showing similarly what it is. It's a break in the inner wall with creation of this almost diverticulus, with just the adventitia covering at the end there. And then finally, the one thing TE can really do a very good job. I imagine CMR does a good job too. I'm not so sure how good a job CT does, is looking at complex atheromas. And we see that quite often when we do our routine TEEs. You can go from nothing to a little bit of thickening to a more modest to big severe. But importantly, not only do you see that, those type of plaques, you can describe them as being diffuse, being localized. This one has a crater, a little crater there. And now, with the X-plane, you can see something a little funny there, and you can bring the X-plane right there and see that very nice raised atheroma. So in the issue of looking for embolizations, this is very, very helpful. This is a complex atheroma with multiple little peaks and valleys, and then you see this unidentified flying object. So that, again, is because of the time resolution of TEE, you have this big advantage of being able to see this. And they can really look pretty cool. Not so cool if you're the patient. But and you can even do a 3D on them. And a long time ago, this was shown by Dr. Vaduganathan, who was one of our fellows, and I'm told that now he's a grandfather, that it was thrombus. When we did a bunch of these patients, took them to the OR. And after that, further studies have shown that these are thrombi attached to these complex atheromas, and we still don't know how to treat them. So trials have been done. There's been a lot of controversy and arguments. The bottom line is that right now, the current recommendations are statins and either aspirin or clopidogrel. Anticoagulants didn't quite show what people were hoping for. So this is still kind of a difficult syndrome to treat. And we see it periodically, and when you see it in the setting of somebody that had been throwing emboli, it can be quite a little nightmare. I remember one single case. I don't think we've done it any more than that, but we had one single case of a lady that had such severe debris covering all of the arch and descending aorta, and she was throwing multiple clots to her legs, that this was in the day where we still have Dr. Safi here. We actually, she went for a thorac-abdominal resection just because of what we thought her risk was. Now, could nowadays you do a EVAR? It's a good thought, right? So if we have some, one of these huge machines and people are throwing them, maybe we can go in and stand them. We haven't seen a case, but maybe one of these days we'll see a patient. So I hope that between the two lectures you're getting a good flavor of this, but I tell you, this is an incomplete presentation to you guys because the aorta is very complicated, and I think my vote is that maybe we think of doing two parts. Maybe acute aortic syndrome being one, and then the other one being all these other pathology that is so important to learn more about. Thank you very much.